We are starting the next session on taming glaucoma, that is medical management of POAG in a nutshell. So the primary goal in the treatment of glaucoma is to reduce the intraocular pressure, as that is the only modifiable risk factor. And as all of you know, there are various treatment modalities available, but still medical treatment remains the primary treatment. And hope after the session, after hearing to all the talks, you'll get an idea on how to start medical treatment, what are the factors to consider, and how to choose the right drug for the right patient, and what are the new drugs available. So let me invite Dr. Lita George to present on anti-glaucoma medications and overview. Dr. Lita is the consultant glaucoma surgeon in Tony Super Specialty Eye Hospital, Aluva. Over to you, Lita.
A very good morning to all of you. So I'll be talking on anti-glaucoma medications. So as we know, glaucoma is a chronic progressive optic neuropathy. Raised intraocular pressure is the most important risk factor for glaucoma. Despite medical researchers working on various other aspects such as neuroprotection, neuroregeneration, and vasoregulation, intraocular pressure remains the only modifiable risk factor as far as glaucoma treatment is concerned. So coming to the history, pilocarpine was the first drug available to us way back in 1875. With newer and newer drugs coming into the picture, glaucoma has largely become a medical disease now, with the surgical indications coming down consistently over the years. In normal individuals, there is RGC loss by apoptosis, which is much faster in a glaucoma patient. The fundamental goal of our treatment is to reduce the cell loss to an age-dependent rate. So whatever be the spectrum of glaucoma, reducing the intraocular pressure helps in decreasing the progression of the disease. You have different modalities for decreasing the intraocular pressure: eye drops, laser trabeculoplasty, and surgeries. But medications are the first choice, probably, because it's well tolerated, you have various options, there is no acute complication, and at any point you can switch to surgery or laser. But it has got its own demerits. It tends to become less effective with time, and you have to escalate your treatment. Long-term use of anti-glaucoma medication is an important risk factor for the failure of filtration surgery. It affects the quality of life, long-term cost, and compliance are other issues. So let's see, what do we have in the basket. We have PG analogs and beta blockers as the first line, alpha agonist and carbonic anhydrase inhibitors as the second line, and now we have the Rho kinase inhibitors and our own all pilocarpine in the third line. So prostaglandin analogs are the first choice drug for primary open angle glaucoma as of now. It decreases the intraocular pressure by 30 to 35%. It is superior to beta blockers. It has got a convenient once daily dosing, which helps in improving the compliance with the treatment. No major systemic side effect except for certain flu-like symptoms. No tachyphylaxis and long-term drift. Cost was an important limiting factor previously, but with the generics in the picture now, cost is no longer a limiting factor. So the mechanism of action of prostaglandin, it basically gets hydrolyzed into its active form and binds to the prostaglandin FP receptors and modifies the extracellular matrix of the ciliary muscle, increasing the uveoscleral outflow. You have the prostanoids, which are the latanoprost, tavoprost, tafluprost, and latanoprost and bunod. The prostamide is bimetalprost. Tafluprost and latanoprost and bunod is not yet available in India. In primary and secondary open angle glaucoma, prostaglandin analogs are the first choice drug. And primary angle closure glaucoma, they do work better after doing a laser peripheral iridotomy. And as we know, prostaglandin is an inflammatory mediator and has to be avoided in any inflammatory glaucoma such as neovascular glaucoma, uveitic glaucoma, and acute angle closure glaucoma. And in aphakics and patients with PC rent, you have to use it with caution as it can predispose to cystoid macular edema. The side effect profile include prostaglandin associated periorbitopathy, cystoid macular edema, anterior uveitis, and reactivation of herpes simplex keratitis. In this era where we are talking about fillers and Botox, prostaglandin associated periorbitopathy is a significant side effect which has to be explained to the patient. You have to convince the patient regarding the benefits of the treatment. The features include eyelitosis, orbital fat atrophy in ophthalmos, hyperpigmentation of the periorbital skin, etc. It is not an irreversible side effect. These features can get reverted after about 8 to 12 weeks of stopping the drug. And when you compare different prostaglandins in the group, studies tell that bimetroprost has got the highest efficacy and latanoprost has got the most favorable tolerability profile, but this is not a hard and fast rule. You start a prostaglandin for one patient, see whether it's working or not, then you can always switch to a second drug in the same group and see whether it's working. So our next group is beta blockers. So the basic mechanism of action is by decreasing the aqueous production by binding to the beta-2 receptors. You have the non-selective and the selective ones. The selective one is betoxolol, but it is less effective than timolol, which is a non-selective one. Despite being a first-line drug, decreasing the intraocular pressure by about 25 to 30%, what makes it a less favorite one for the glaucoma practitioners is its side effect profile and tachyphylaxis. You can have numerous systemic side effects like bradycardia, heart failure, pulmonary side effects like exacerbation of asthma, neurological side effects, masking hypoglycemic symptoms in diabetic patients. All these are the systemic side effects associated with the use of timolol. And the second thing is tachyphylaxis, that is loss of IOP lowering efficacy over time. It can either be a short-term escape or it can be long-term drift. Short-term escape can be due to either upregulation of the beta-adrenergic receptors, or it can be due to a change in the receptor sensitivity itself. In long-term drift, the drug may work for months or years. After that, you tend to lose its efficacy. It can either be due to drug tolerance or it can be due to the progression of disease pathology itself. That is due to progression of trabecular meshwork outflow problems. So you have to avoid this drug in cardiogenic shock, decompensated cardiac failures, heart blocks, and reactive airway diseases like bronchial asthma and COPD. Alpha agonists do have a dual mechanism of action. They decreases the aqueous production and also increases the uveous scleral outflow. You have the non-selective and the selective ones. As of now, brimonidine is the only one which is available to us in the Indian market. Brimonidine is available in 3 concentration, 0.2, 0.15 and 0.1%. You are trying to decrease the concentration in order to decrease the side effect profile. The neuroprotective action of brimonidine is well established in animal studies, but when it's not clinically proven. And coming to the side effect, ocular allergy and follicular conjunctivitis is a notorious side effect of this group of drug. Epreclonidine, which was available to us in the early 2000s, has been withdrawn because of the side effect, which was reported in around 50% of the patients. With brimonidine, it is reported in around 20 to 30% of the patient. The patient may be using this drug for years. It's a delayed type of hypersensitivity reaction. Patient may be using this drug for years, and at a later point, patient comes with follicular conjunctivitis, which may be mistaken for viral conjunctivitis. But you have to stop this drug when patient comes with follicular conjunctivitis. And systemic side effect includes hypotension, drowsiness. So be careful while using this drug in drivers, elderly, and heavy machinery operators. It crosses the blood-brain barrier and causes CNS depression, so has to be avoided in children less than 6 years of age, preferably to be avoided in children less than 10 years of age. The next group of drug is the carbonic anhydrase inhibitor. You have dosolamide and brinzolamide as the topical agent, acetazolamide and methazolamide for the systemic use. Again, the mechanism of action is by decreasing the aqueous production by inhibiting the carbonic anhydrase enzyme. Dosolamide has got an acidic pH with a thrice daily dosing. Brinzolamide has got a neutral pH with a twice daily dosing, and it's a suspension, so has to be shaken well before use. Since it has got a neutral pH, brinzolamide is thought to be better tolerated than dosolamide. And another practical point is, please do avoid this drug in patients who have decompensated cornea and who are corneal graft recipients, as it can precipitate corneal edema. And side effects, when used topically, it can cause allergic reactions of the conjunctiva, superficial punctate keratitis, and metallic aftertaste. Systemic drug is acetazolamide. The dose is 250 milligrams 4 times a day. That is the maximum dose, but it has got a lot of systemic side effects. Elderly patients may find it very difficult to tolerate the drug. The side effects include paresthesias, hypokalemia, metabolic acidosis, renal stones, etc. Rho kinase inhibitors are the newest drug which is available to us. It has got a novel mechanism of action by improving the aqueous outflow. Rho kinase inhibitors, they alter the cell shape in the trabecular meshwork, allowing improved aqueous humor outflow. You have two molecules, one is netarsudil and the other one is ripasudil. Netarsudil, in addition to improving the aqueous outflow by blocking the norepinephrine transport inhibition, it reduces the aqueous humus production and also it reduces the episcleral venous pressure. It has got a once daily dosing, and ripasudil has got a BD dosage. Finally, a word about pilocarpine. Even though this is an all drug, it works as a wonder drug in certain specific situations, particularly in pseudophakic with angle closure glaucoma, it may work. So to conclude, know your drug so that you can make a better choice for your patient. Thank you.
Excellent presentation, Lita. Now, basic considerations before starting treatment in a glaucoma patient by Dr. Girija K. Madam is the head of the Department of Glaucoma Services, Little Flower Hospital.
So, basic considerations before starting treatment in a glaucoma patient. As you know, the elevated intraocular pressure is the only modifiable factor, and we try to reduce it to prevent progression of the glaucoma. So, a patient, a 55-year-old female, comes to you with an IOP of 28 in the right eye and 27 millimeters in the left eye. The CCT is in slightly thinner, 507 and 508. And the cupping, right eye shows a 0.8 cupping with superior and inferior thinning, and the left eye a 0.6 cup. So if you look at the field, there is superior aqueous scotoma in both the eyes, even though the left eye is showing only a 0.6 cupping. But the IOP is definitely high, and the OCT also is green. But since there is cupping and there is asymmetrical cupping, you can consider, and the IOP is high with this because we have repeated the fields 2 or 3 times and we got consistent results. So the diagnosis was a primary open angle glaucoma. So how to proceed in such a case? So first you establish the diagnosis, then you establish a baseline IOP by at least measuring once or at least twice or thrice, and then you set a target IOP. This target IOP has been the dogma that has been dominating the glaucoma world for several decades now, and it was reinforced by the post-hoc analysis of AGIS, which states that an IOP of 18 millimeters of mercury in all visits or an average IOP of 12.3 millimeters has halted the glaucoma progression in that large study. So this, it is assumed that the target IOP, if the patient is having target IOP, then the glaucoma will not progress, and if it is below target IOP, it's better, and if it's above, then the disease can progress. But this is not a magic number. You have to individualize and find out the target IOP for each and every patient. Always it should be individualized with an aim of preventing disease progression and also to not to affect the quality of life of the patient. So what are the factors you should consider? You should consider the age of the patient and the disease, the structural damage, the functional damage, and the baseline IOP at which the damage has occurred. And also consider the other additional risk factors like comorbidities and ocular diseases. So target IOP can be calculated by formulae, or there is the rule of thumb which states that mild disease requires 20% reduction, moderate 30%, and more than 40% in severe glaucoma. But one thing you have to be aware, the higher the IOP, the larger is the reduction required. That is, if the patient is coming to you with 60 IOP, then a 40% reduction is not enough. You have to bring it down to the normal level. And the target IOP actually doesn't consider the risk or the side effects. So what are the factors to consider before initiating treatment? So you have to find out whether the disease, what the disease is. That is it open angle glaucoma or a narrow angle glaucoma? And if it is open angle glaucoma, then straight away the first choice is medical treatment. And you have to stage the disease to start drug, because how much percentage of reduction you require, you have to decide. So you have to consider the patient factors. One is the age. Many of these topics that I am discussing may be previously discussed by Lita, so there may be some amount of overlap. Please excuse. The age is, if the patient is young and the patient is having an aggressive disease, then you have to start more percentage of reduction, so you have to start a prostaglandin analog. But if it is a younger patient, then less percentage of reduction is required, so you can wait and you can start a milder drug. Then in children and young adults, you may have to avoid certain group of drugs. So, and also consider the associated ocular diseases and other comorbidities, systemic comorbidities. Like beta blockers are absolutely contraindicated in COPD and heart block. But in cardiac failure, actually, beta blockers are systemic beta blockers are given, and you can give topical beta blockers. Then prostaglandin analog, when you're starting, you have to, there are other considerations like pigmentation of the iris and pigmentation of the skin, especially when you want to start unilateral treatment. So these figures show the change of iris pigmentation, like the brownish eye, even the brown has become darker. So if you are starting in one eye, that may cosmetically, it may not be acceptable to the patient. So you have to explain it. The periocular pigmentation also, in fair skin people, if it is uniocular, better start some other drug. And always consider the compliance, because once daily dosage may be more acceptable, but twice or thrice daily may not be accepted by the patient. Then if there is any history of allergy, that also has to be kept in your mind. So how to choose the appropriate drug? This will be dealt in detail by Dr. Manju, but I'm just saying the important points. So find out the IOP lowering effect, whether you can reach the target IOP with this particular drug. So there are various drugs that are available. So always consider the efficacy, the compliance, and the safety profile. If the drug is cost effective and the dosage is convenient, compliance always improves. And the fixed drug combinations have always improved the compliance and cut down the costs. And another thing to consider is when systemic drugs are given, especially in beta blockers and carbonic anhydrase inhibitors, it can reduce the effectiveness of the topical drug. So better avoid giving them together. If there is no other option, you have to give. So the advantages of prostaglandin analog has already been discussed by Lita. So once daily dosage and the 30 to 35% IOP reduction makes it the first drug of choice. And it gives a diurnal and nocturnal IOP lowering. That makes it the superior drug. But it has got so many side effects which you have to consider. Except for that, it is free of systemic side effects and it can be tolerated by many. And the beta blockers, because of the systemic side effects, it is actually it has to be started with caution. And another thing to remember is the nocturnal lowering of IOP is actually very minimal for beta blockers. And especially the systemic side effects also you have to keep in mind, and always advise the patient about punctal occlusion. So this is a 78-year-old patient who was referred for management of neovascular glaucoma of the right eye. Patient was referred from another center. She was already started on Mysopt, and she was waiting in the waiting area, and she collapsed in her OPD waiting area. So she was taken to the emergency, and her BP was very low, 90/60, and heart rate was also 40 per minute. So there was a patient was taken to the emergency, and ECG was taken. A sinus bradycardia was diagnosed, and the cardiologist has seen the patient was on systemic beta blockers. So it was stopped by the cardiologist. And the symptoms recurred again after stopping this thing. Patient went home, but again the patient had the same symptoms. So on close questioning, we got the information that it is happening after the Mysopt. And it was stopped, and then patient got relieved. So you have to be aware that the systemic bioavailability of ophthalmic timolol is around 78%, and it reaches the circulation in 15 minutes. So that has to be kept in your mind. The 24-hour IOP control is much better for prostaglandins. And something else is adjunctive therapy. When you're combining prostaglandin with timolol or dorzolamide, you get a better effect. Especially with dorzolamide, now the combination with dorzolamide is supposed to be superior than that with timolol, because PGA induces a carbonic anhydrase enzyme in the epithelial cells of the ciliary process, which can result in an increased echosumor production, and this can be countered by the carbonic anhydrase inhibitor dorzolamide. So that combination is better than the other one. And concomitant use of pilocarpine and prostaglandin analogs may be mutually antagonistic. This is a 55-year-old female that I have, so that case was already discussed. So the patient was actually, because the IOP was 28 and 27, she was started on prostaglandin, travoprost, once daily, and the patient was on follow-up. The IOP came down to 21 and 19. So because the right eye was having cupping, brimoinidin was added. And the IOP came down to 16 and 15. Because she was having asthma, we couldn't add Brimalol. But after 6 months, the patient came back with pain and redness, and she was having uveitis, severe uveitis, which did not resolve even after stopping travoprost. So instead of travoprost, we started dorzolamide and along with the uveitis management. But uveitis persisted. So only after stopping the brimoinidin, the uveitis resolved. So you should be aware that brimonidine can cause granulomatous uveitis, and you have to keep that in mind. So management for each patient should be customized and consider the patient as a whole, not the IOP alone, and while deciding on treatment, and choose the appropriate drug. Keep in mind the cost, dose, and the side effect, and reset the target IOP on follow-up visits. Thank you.
Thank you, madam, for that wonderful talk. Now, Dr. Manju Anu will present on choosing the right drug for each patient. Manju is a glaucoma consultant in Giridhar High Hospital, Kochi.
Good morning all. Thank you Girija ma'am for giving me the opportunity. So I'll be talking on the management of POAG, choosing the right drug for each patient. Most of the points which I was supposed to cover was already covered by Elita and Girija ma'am. So the aim of the treatment of glaucoma is to preserve the visual field integrity and the quality of life. And currently, the only approach proven to be effective in preserving the visual function is lowering of IOP. So for that, to know how much the IOP should be reduced, you should have a good baseline IOP, which you need at least 2 to 3 baseline readings. And then based on multiple factors, you have to set the target IOP, which is the IOP at which further progression is arrested or the rate of progression is sufficiently slow. This is my favorite slide from UGS guideline. While setting the target IOP, you have to consider multiple factors, that is the stage of the disease, life expectancy of the patient, baseline IOP, additional ocular and systemic risk factors, rate of progression, and also the central corneal thickness. So based on the target IOP and the baseline IOP, you have to set the target, and then you have to decide which AGM should be started. For that, you know the aqueous humor dynamics, which was already covered by Lita. The aqueous humor is produced from the ciliary body, and the outflow includes trabecular and uveoscleral outflow. And based on the site of action, the drugs are grouped into various classes. And I'll be talking about only the salient features which you have to consider while deciding your AGM of choice. The first one is timolol, which is commonly used beta blocker. It gives about 20 to 25% reduction of IOP, and the duration of action is 12 hours. So commonly used dosage is twice daily. But we have some long-acting preparation which can be used once daily. Timolol is well tolerated topically, but it has deleterious effects on various systems like cardiovascular, respiratory, CNS and all. So you have to consider all these systemic risk factors while deciding on giving timolol. Then short-term escape and long-term drift already covered, and peak effect of washout is 4 to 6 weeks. Alpha agonist, the only one which is available in India is brimonidine, and it again gives 20 to 25% of IOP reduction. The duration of action is 8 hours, so we can give it as a TID dosage in monotherapy and give as a combination, BD in combination. The most common ocular side effects include follicular conjunctivitis and allergic dermatitis, which can occur even after many years of starting the drug. It causes CNS depression, and it is contraindicated in children below 4 years. Now we have BAK-free formulations of brimonidine. Carbonic anhydrase inhibitors, we have dorzolamide and brinzolamide. This group gives 15 to 20% reduction. So dorzolamide as brimonidine you can give as TID in monotherapy and BD in combination usage. Brinzolamide is twice daily. We have again BAK-free formulations available, and the side effects already covered. Myotics, we have pilocarpine. It gives 20 to 25% reduction, and it's 2 to 4 times daily, mainly useful in angle closure diseases. It has both systemic and ocular side effects, contraindicated in active intraocular inflammation, recent MI and peptic ulcer. Rho kinase inhibitors are the recent drugs which we have ripasudil and netasudil, 15 to 20% reduction. Ripasudil is twice daily dosage and netasudil is once daily. But the most common side effects include conjunctival hyperemia and irritation. Many patients are coming back with these symptoms, and I had to stop the drug. No long-term results available. Coming to the prostaglandin analogs, we have latanoprost, tauprost, bimetoprost and tafluprost. This gives the maximum IOP reduction among the topical anti-glaucoma medications, which is 25 to 35%. it has more of ocular side effects and minimal systemic side effects. The duration of action is 24 hours and the dosage is once daily. We have many drugs which are available as fixed dose combination. The recent one is brimonidine, brinzolamide, timolol, which can be given as twice daily. Systemic medications, I'm not going into the details. Acetazolamide 25 mg QID or sustained release 500 mg BD per oral. Mannitol 20% solution 5 ml per kg body weight IV, and glycerol 50% solution 3 ml per kg body weight oral, which can be, all these can be given for a short term. Now, to consider the first choice of treatment, you have to consider both the patient characteristics and the drug properties, which include the clinical picture of the disease, safety profile, both systemic and ocular, adherence to the treatment, and the quality of life of the patient. Also, the drug properties, which include the mechanism of action, efficacy, the target IOP, preserved or unpreserved. Many patients now comes back with the AGM anti-glaucoma medications allergy. Maybe unpreserved ones are a better choice. And also consider the cost. So after considering all these drugs, the most commonly used first line include PG analog and the beta blocker. The second line include alpha agonists, carbonic anhydrase inhibitors, and Rho kinase inhibitors. And you have to make sure that the adherence and persistence with the AGM, and call the patient after about a month's time. And on review, check the IOP, and suppose your target IOP is achieved, continue the same treatment. Your target is not achieved, but the IOP reduction is less than 15%, don't use that drug, keep it as a reserve and substitute with another one. The target is not achieved, however, the IOP reduction is more than 15%, you keep that drug and add another drug. So now let us look at some case scenarios. This is a case of 56-year-old female with a family history of glaucoma. Anterior segment and fundus examinations were within normal limit except for an intraocular pressure of 24 to 27 on diurnal, and the central corneal thickness was only 490. So this was a case of ocular hypertension, and because of the multiple risk factors along with the ocular hypertension, I decided to start treatment. So what should be your target IOP and what should be your AGM of choice? Here the life expectancy of the patient is long and the baseline IOP is high, and patient has additional risk factors and also the thin cornea. So I decided to set a target IOP of about 20 to 25%. So because I need only 20 to 25%, I started with timolol and once daily dosage. So after 3 weeks, the IOP was 20 millimeters of mercury, that is, we achieved about 26% reduction. So I decided to continue the same treatment. The second case is a 63-year-old female with a family history of glaucoma and systemic factors like DLP and hypothyroidism. Intraocular pressure was 26 in the right eye and 28 in the left eye. Anterior segment was showing early lens changes. However, the disc was showing advanced damage with involvement of the central 5 degrees of fixation. So this was a case of both eye primary open angle glaucoma. So here what should be your target and what is the AGM of choice? So the disease is advanced, the long life expectancy of the patient, and high baseline IOP, presence of additional risk factors. So my target was about 35 to 40% reduction, that is 14 or less, because the advanced glaucoma intervention study shows that if the IOP is consistently below 14, the progression is less. So I started with the prostaglandin analogs, which gives the maximum IOP reduction among the topical drugs. And after a month, the IOP has reduced to 18 millimeters, that is about 31 and 35% reduction. The target is not achieved, but the drug is working. So I decided to add one more drug to get an target IOP. And I added timolol 0.5% BD, and after a month, the IOP has reached and my target is achieved. So I decided to continue the same drug. This is a third case, 80-year-old male, post-angioplasty and history of prostate surgery. The intraocular pressure was 15 to 17 and 15 to 18 on diurnal variation, and the central corneal thickness was 530. Anterior segment was pseudophakic. However, the disc was showing advanced damage in both eyes with the split fixation in the left eye. So this was a case of a normal tension glaucoma, and what should be your target and what is the AGM of choice. So here the disease was advanced, the life expectancy was short, and untreated IOP was low, and presence of additional risk factors. So considering the normal tension glaucoma, I set a target IOP for about 25 to 30% reduction and started with brimonidine thinking that some neuroprotective action. But after a month, the IOP was again 16 millimeters of mercury only. So my target is not achieved and the IOP reduction was less than 15%. So there is no point in continuing with this drug. So I decided to switch to another drug. So I started with latanoprost once daily dosage, and after a month the intraocular pressure was 11 millimeters of mercury and my target was achieved. So I decided to continue with the same medication. So to conclude, once you decide to start treatment, you should have a good baseline IOP and set a target IOP. Start with monotherapy as much as possible, and if very high IOP, you can use fixed dose combination. Try to use preservative-free formulation wherever possible. Otherwise, you can even use generic drugs if they are working. And you have to make sure that adherence and persistence with the anti-glaucoma medications. Thank you.
Thank you, Dr. Manju, for that excellent presentation on how to choose the appropriate drug. Now I invite Dr. Smita to talk on anti-glaucoma medications in pregnant, lactating and pediatric patients, which is a common dilemma that we face in our OP. So Dr. Smita works as a consultant glaucoma surgeon in Little Flower Hospital, Angamali. Over to you, Smita.
Good morning all. My topic is anti-glaucoma medications in pregnant, lactating and pediatric patients. Glaucoma is very rare in pregnant ladies. It occurs in about 2 to 3%, and it may be a pre-existing early childhood glaucoma, or it may be associated with other coexisting conditions like uveitis or diabetes. So glaucoma in pregnancy is a challenge to the treating ophthalmologists, as they should keep a balance between the risk of vision loss to the mother as against the potential harm to the fetus, as these drugs will cross the blood placental barrier and reach the fetus and cause teratogenicity. And there are very few evidence-based recommendations seen in literature. And during pregnancy, the IOP decreases. It is more marked in the third trimester, and it persists for several months post-op. The largest IOP decline is seen in 12 to 18 weeks in non-glaucomatous patients, while it is seen in 24 to 38 weeks in ocular hypertensives. About 10% of glaucoma patients progress during pregnancy, so we have to monitor glaucoma during pregnancy. There is a decrease in IOP, and this is due to an increase in the uveoscleral outflow, and progesterones act as a glucocorticoid receptor antagonist in the outflow apparatus, and it inhibits the ocular hypertensive effect of endogenous steroids. There is generalized decrease in the upper extremity venous pressure and peripheral vascular resistance, which decreases the episcleral venous pressure. And the maternal metabolic acidosis also leads to decrease in IOP. FDA has classified these anti-glaucoma medications into 5 categories. Most of the anti-glaucoma medications come in category C, where there is unsure safety. That is, the animal studies have shown evidence of harm to the fetus, but there are no adequate and well-controlled studies in pregnant women. Brimonidine is the only drug which comes under category B, where there is a presumed safety. Animal studies have not shown evidence of harm to the fetus, and there are no adequate and well-controlled studies in pregnant patients. When we administer topical drops, we have to do eyelid closure and nasolacrimal occlusion, as we can decrease the systemic absorption by 60%. Punctal plugging and blotting the excess drops away also helps to reduce the systemic absorption. For the fetal safety, we have to use the fewest number of drops with lowest concentration and least number of times each day. Coming to the teratogenic effects of glaucoma drops, beta blockers have caused intrauterine growth retardation and cardiac conduction defects. Carbonic anhydrase inhibitors can cause oral limb defects in animal studies. Prostaglandin analogs can increase the uterine tone and decrease the perfusion of the fetus, and it can also precipitate miscarriage and premature labor. Parasympathetics like pilocarpine can cause neonatal hypothermia, restlessness, and seizures in newborn. And brimonidine is the safest drug to use during pregnancy. To summarize, brimonidine is the only drug in category B which can be recommended in the first and second trimester. It should be avoided close to delivery because of the neonatal effects. Beta blockers belong to category C, and it can be used in the first and second trimester, but is better avoided in the third trimester because of the risk of neonatal effects. Prostaglandins also belong to category C, and it can be used in the third and possibly in the second trimester because of the risk of early labor. And calcium anhydrase inhibitors, it can be used in the late second and early third trimester. Pilocarpine can be used in all three trimesters. And Rho kinase inhibitors, they are not categorized, and they possibly can be used as based on the animal studies. If the IOP is not controlled with medications, then next option is selective laser trabeculoplasty. It can decrease the medication burden or can eliminate the medications, but it is less effective in people less than 40 years, and it requires an open angle. Surgery is another choice if the IOP is not under control, but it is better to avoid in first trimester, and there is risk of anesthesia, so it's better to use topical anesthesia, and use of post-operative medication should be done carefully, and these patients should lie down for supine position for a long time, so it is difficult for these patients. And coming to the medications during lactation, all these medications can can reach the breast milk, and so it can cause harmful effect on the babies. Alpha-adrenergic agonist, that is brimonidine, is contraindicated. It is contraindicated during lactation while it is used in pregnancy. This contraindication is due to risk of CNS depression, lethargy, and bradycardia. This is very important. Beta blockers are safe, but we have to be cautious in infants with cardiopulmonary disease. Prostaglandins are likely safe since they have a short half-life. Pilocarpine safety is unknown as there is risk of cholinergic exposure. Calcium anhydrase inhibitors are safe as they have short half-life. And Rho kinase inhibitors safety is unknown. So the recommendations for glaucoma medication during pregnancy and lactation. During pregnancy, first line of treatment is brimonidine and second line is beta blockers. During lactation, first line is topical carbonic anhydrase inhibitors, alternative is timolol and prostaglandins. In summary, before conception, for those patients who attend in our OPD, who are in the childbearing age, you have to inquire about the pregnancy. They will not volunteer you about the pregnancy. And a discussion of treatment goals, that is target IOP, treatment options, and strategy, that is stopping or changing the current regimen, should be ideally held in pre-conception period. And treatment decisions should be shared with the entire healthcare team, like obstetrician, pediatrician, etc. And close follow-up needed throughout the pregnancy. Identify drops that are safe. Laser therapy can be safely performed during pregnancy and lactation. And drops should be administered with a nasolacrimal occlusion and eyelid closure. And since this passes through the breast milk, it should be given immediately after the feeding session. And coming to the management of pediatric glaucoma, surgery is the mainstay of treatment, as in primary congenital glaucoma and glaucoma associated with ocular anomalies. Medication is given as a temporary measure to clear the cornea to allow goniotomy, awaiting surgical clearance, post-op, etc. And long-term or permanent medical treatment when the target IOP is achieved without surgery, and in cases of secondary glaucomas like post-traumatic glaucoma, post-cataract surgery, steroid-induced glaucoma, etc., we can give medical management. And there is very high risk, if the patient is very high risk for surgery with moderate increased IOP, and if the patient is unwilling or unfit for surgery, and palliative treatment in non-seeing eyes, and post-op after successful surgery. This is an article in Journal of Current Glaucoma Practice, where medical treatment is successful in about 53% of secondary glaucoma. And another article in IJO about the profile of childhood glaucoma at tertiary center in South India. So showed a significant patients were treated with medical management, and it is effective. And coming to the Graves Archive, that is a review article on the medical management of pediatric glaucoma, lessons learned from randomized controlled trial. There are very few RCTs in pediatric glaucoma because of the safety and ethical concerns. They have the IOP lowering efficacy similar to that of the adults, as in 25% with timolol. And Latanoprost, it is about 26, and Travoprost, it is 27. And coming to the responder rate, it is less responding compared to that of the adults. With timolol, it is 47%, Latanoprost is 60, and Travoprost 83%. So the efficacy is similar to adults. Responders, they are less than in adults, and they have high systemic absorption. The systemic absorption of topical timolol is similar to that of the oral or IV administration. They should be careful when giving topical timolol, since they have the blood retinal and blood brain barriers are not fully developed. There is a small volume of plasma and lower concentration of principal plasma binding protein. So we have to use the lowest dose, preferably gel formation and lacrimal punctal occlusion. Beta blockers can be given, and the mean IOP is 20 to 25%, and it should be avoided in premature and small infants. Prostaglandins have good efficacy. Carbonic anhydrase can be used as a first or second line therapy in young children. Rimonidine is contraindicated in children less than 6 years, weight loss less than 20 kg. Children with CNS depression or CNS response cannot be assessed. So medical treatment of pediatric glaucoma, there is low medical adherence is seen. This is a challenge. So barriers to medication adherence include forgetfulness, complex dosing regimen, and being too busy with other activities. So monitoring of the pediatric glaucoma patients is important. Proper and timely monitoring is necessary for the best outcome. General examination should include all the vital signs and alertness, especially in beta blockers and brimonidine. Parents should be asked for the adverse reactions, and detailed ocular examination like IOP, corneal clarity, and optic nerve head examination should be done. And examination under anesthesia may be needed in some cases. Thank you.
Thank you, Dr. Smita, for that wonderful presentation. Now I invite Dr. Meena Gopinath Menon to talk on new anti-glaucoma medications in pipeline.
Good morning.
Dr. Meena is the glaucoma consultant in Shankara Eye Hospital, Bangalore. She did her MS from Aravind Eye Hospital, Madurai, and took her FRCS in 2001. Over to you, Dr. Meena.
Thank you, Dr. Girija. Thank you, KSOS, for giving me this opportunity. So my half job is done by Litta and other speakers. So anti-glaucoma medications have gone through a lot in past 20 years, starting with new single drug, fixed combinations, and some of them are the newer addition to these armamentarium. Some are already existing. So when we talk about pharmacological agents, I'm like slightly modifying the title. It's not only in the pipeline, it's already available. Rho kinase inhibitors, it is being dealt already. So I'm just going through a little studies which are conducted about the ROCK inhibitors. So ROCK inhibition usually relaxes the trabecular meshwork, it increases the outflow. And norepinephrine transport inhibition also reduces the aqueous humor production, and it lowers the episcleral venous pressure. Now, there are certain additional benefits with this group of drugs, being protection of trabecular meshwork cells from oxidative damage, it facilitates corneal endothelium wound healing, it increases the ganglion cell survival, and there have been few literature which shows that there is a reduction in bleb scarring in glaucoma surgery. But being some of the downside is it's not effective in angle closure glaucoma, and it can worsen uveitis, and the main side effect being conjunctival hyperemia. Now, the prototype, one of the drug is Ripasudil, 0.4%, which is being used for open angle glaucoma and OHT, which gives a 15% IOP reduction. But as you can see, it's got a very high rate of conjunctival hyperemia. The other drug being Netasudil, it is given as a once daily dosing, which gives a 22% IOP reduction. And again, it has got various mechanisms like aqueous humor outflow is increased, reducing the EVP and reducing the synthesis of aqueous humor as well. The conjunctival hyperemia in this group is almost 53%, other side effects being cornea verticillata and conjunctival hemorrhage. When we talk about cornea verticillata, what is it? It's basically lipid microdeposits in the corneal epithelium, which is due to phospholipidosis. Now, usually this resolves. Once you stop the drug, it usually resolves in 13 weeks, and it doesn't cause any change in visual acuity. When we talk about the conjunctival hemorrhage, it is usually seen sporadically, usually in the limbal area, unilateral most of the time. Small micro hemorrhages are seen. This is one very common side effect which we see day in and day out after we started using this group of drug called as honeycombing. This is basically a reticular epithelial corneal edema, which is usually seen with the use of either Ripasudil or Netasudil. Most of the time, this is seen with the patients who have already existing corneal endothelial problem. So basically, this group of drug is a double-edged sword. Even though they say that corneal endothelium is protected with this drug, but sometimes we do find this side effect very commonly. Some of the studies, landmark studies, Rocket 1 and Rocket 2, wherein they compared the Netasudil with Timolol maleate, and they found that it is statistically non-inferior to Timolol. The other group, other drug in this group is a combination drug which at present is not available in India, that is Netasudil with Latanoprost combination, but unfortunately the ocular hyperemia is quite high in this drug. The landmark trials being Mercury 1 and Mercury 2 trials, wherein they found that this fixed combination when compared to monotherapy with Netasudil or Latanoprost showed a promising result. Now we are all with this tag. This is the world's first fixed dose combination of brimonidine, timolol and brinzolamide, which has been brought in India, which is called as Trisop, no financial interest. And this is the other study which I have been fortunately to be a part of it, but still it is not at FDA approved, which is bimatoprost, brimonidine and brinzolamide. It was a multi-central trial all over India. Some of us might be a part of it. Most of the organizations were part of it, but it's still it is published in clinical ophthalmology, but is still not approved. Other group of drug which is in pipeline is nitric oxide donors or prostanoid receptor agonist, which has got all kind of properties, like it helps in neuroprotection, it decreases the IOP and increases the blood flow as well. Now in this group, the drug's name is Latanoprost Bunod. It is currently not available in India. It's marketed as Vysutla, 0.024%. It is given as a once daily. Now, this is usually metabolized into latanoprost acid and butanediol mononitrate, which is, so it helps in all the pathways, uvascleral, conventional outflow, all this is helped by this particular drug. Now, the Apollo study is the landmark study of Latanoprost Bunod, where they compared with Timolol maleate in patients with open angle glaucoma or ocular hypertension, and they found that once a dose of Latanoprostone Bunod, when compared to twice daily Timolol maleate, mean IOP was significantly lower in the LBN group. The other study is the Luna study, wherein they compared the same latanoprostone with timolol maleate. Now in this group they had a placebo group also. So they found that definitely this is non-inferior to timolol and safety is good. Again, this was one of the primary studies wherein they found the long-term safety and efficacy of latanoprost in Japanese subjects, which is called as Jupiter study. So again, it was a multi-centric trial which they gave the drug for almost 52 weeks. It was evaluated every 4 weeks for the safety, and they found that the mean reductions was significant, almost 22% and 19.5% was achieved by 4th week. So it is safe and well tolerated. In Japan, it is very well available in the market. Now, all these studies are very interesting names. This is a Voyager study wherein they compared latanoprost bunod with latanoprost. All this while we were talking about latanoprost bunod with timolol. Voyager study compared with latanoprost, and they found that a significantly greater reduction in mean diurnal IOP, because that's one of the worry which all of us have. So this definitely considered the mean diurnal IOP also. The other is a constellation study, wherein again they compared latanoprost bunod with timolol in controlling the pressures over 24 hours. So this also they found that this is non-inferior and it controlled the diurnal as well as the nocturnal IOP. This is the other drug which is already available in Japan. It is called as omidine PAG isopropyl. It is an prostanoid EP2 receptor agonist. Now it increases the aqueous humor outflow, and some of the side effects being conjunctival hyperemia and corneal thickening has been noticed in these children. The other group is oligonucleotide based compounds. Most of them are in clinical trials. As you know, pegotamine and already being used by the retinal surgeons for NVG, aganirsan and bimosiran are in the clinical trials right now, mainly for NVGs. Neuroprotection, we always talk about this neuroprotection. There are various drugs which are being used, neurotrophins, glutamate antagonist, calcium channel blockers, nitric oxide inhibitors, antioxidants. This shows different pathways where it acts in as an anti-glaucoma drug. Now just a word about drug delivery implants. So these are not currently available in India, but it is hugely being advocated all over. So one of the common one which is FDA approved is Durista or bimatoprost implant, which is available as a 10 microgram. That is what is FDA approved. They were doing clinical trials with 10 and 15. Now this study is called as Artemis 1 trial, wherein they compared Durista of 10 microgram and 15 microgram, and they found that it is definitely non-inferior to 0.5. Now how does it place? So this is like a DEX implant wherein you have an injector and it is placed at the anterior chamber angle. So this is what you can see as an implant which is placed in the anterior chamber angle. Now what is the main concern? Main concern was drop in corneal endothelial cell density. Rarely patient had conjunctival hyperemia, foreign body sensation, but the main problem was cornea. The other being bimatoprost ring. So this is a small ring, polypropyl ring, which we place it in the limbus fornices, upper and the lower fornices. The other one is, which is the pipeline. This is really in the pipeline, travoprost punctal plugs. So it is placed in the punctum and it has got a filtered light. So we will know whether the device is in the punctum or not because it contains fluorescein. So iDose travoprost is again placed in the trabecular meshwork as an implant. So this is a study which is a very well written study, newer advances in medical management. From this I have taken this chart wherein they have enumerated what are the ones which are preclinical, ongoing clinical trials and which are already in use in clinical practice. Thank you.
Thank you, Dr. Meena. That was an excellent presentation. Most of us are not familiar with these drugs that you mentioned in your presentation, but it just gave us an idea about what all are coming. So we have hope for newer drugs in the future. So thank you very much. So this will bring us to the end of the session. Any questions? We have 5 minutes for discussion. Any questions, please?
Good evening, ma'am. Good morning, ma'am. I just want to ask, suppose in resistant glaucomas, I've seen people you're giving a combination of 3 drugs. And will you add a rho kinase inhibitor as a 4th drug in such resistant glaucoma, for example, secondary glaucomas? That is one question. Second question is, you are saying that brimonidine, it causes uveitis, even though in very minuscule of people. But what I've read is that it's very common in people above elderly age group. It's about 70, 75 years. It's not so common in the usual middle age group. So if it is causing uveitis, you cannot, is it contraindicated in uveitic glaucomas, brimonidine? But usually you've seen people above 70, 75 years of age, Brimodine causes uveitis. It's not very common in middle-age groups. That's what I've heard of.
Actually, brimonidine causing uveitis, we don't see that often. We have seen only in very few patients. Even prostaglandin analogs, actually it is contraindicated in uveitis, but in NVG we give prostaglandin analogs. So you have to individualize your treatment and follow up the patient carefully and stop the drug if there is any other side effect. So I think that is the way you have to manage.
Regarding ROCK kinase inhibitors, the fourth drug,
I use a lot of ROCK kinase inhibitors because of this problem. Like we don't have any other drug as a fourth drug, but quite a few side effects we are noticing, especially conjunctival hyperemia. The picture which I put is my own patient with honeycombing, because many a time secondary glaucoma, especially post PKP, we are seeing honeycombing a lot. Now, like one of my cornea consultant feels that if we continue, it is disappearing. But it's a little difficult for me to stay at this stage, whether it will disappear in spite of being used for a longer time.
does this fourth drug actually reduce the IOP in a significant manner?
It does help.
Fourth
It does
drug.
help.
As you had a ROCK kinase is the fourth drug.
Yeah, it does help. Definitely it does help. And to add on to Dr. Girija's answer, like brimonidine is, as of now, it is not like a total contraindication in uveitis. Because in uveitic glaucoma, many a time corneal endothelium is also compromised. So you are little reluctant to use a dorsalamide component also. So you still can use brimonidine, but be aware that this can exacerbate. So just keep a watch on that. That should be okay.
Thank you.
Good morning, Girij. It was an excellent program. And two things. One is, if you have an open-angle glaucoma patient coming in who is on a steroid inhaler, what is your advice? We see these days, post-COVID, so many patients are on steroid inhalers. What is the association? Do you ask them to stop and go into non-steroidal medications, or do you ask them to continue? The literature says not to, it has no effect, literature says, but we see many patients on inhalers, pressures at 25, 35 with an open angle glaucoma. What's your take on that?
So steroid inhalers, it's really whatever literature reports, generally what it says is very long-term use. But currently I think there are quite a few kind of non-steroidal or a low-potent steroid inhalers which are available. Now considering their systemic problem, I generally don't advocate them to stop. Its only thing is that the patient has to be aware, and if it's an advanced glaucoma, preferable definitely whether in consultation with the physician they can reduce it. But inhalers, I have not really asked them to stop just because of glaucoma. Basically, patients have to be aware of inhalers also can cause this problem. So monitoring of and progression of glaucoma, we have to be aware of. That's it.
In advanced such cases, will you advise surgery for such patients? Because steroids you cannot stop.
Yeah, definitely. Like if the IOP is not controlled and patient has to have an inhaler, steroid inhaler, probably surgery can be an option. Definitely, if it is uncontrolled.
So I think we'll wind up the session and clear the hall. Thank you very much for attending the session. First, let me invite